Hello everyone, welcome to this presentation on the on the precision and accuracy of clinical examination, JAMA Chapter 1. This is Dr. Sulfam Razgiri here. So the contents is how to choose a test, basic statistical parameters such as sensitivity, specificity, positive and negative predictive value, Kappa value, pre-test and post-test probabilities, and likelihood ratio. So starting with the basics. So this is a 2x2 table which we'll be using throughout this presentation. Here in the row side we can see the test parameters, that is whether the test is positive or negative, and on the column side there are disease parameters, so that is disease present or absent. So in this we can see that the A is a condition known as true positive, where the test is positive in patients in whom the disease is present, whereas D is a condition where known as true negative, where the test is negative and disease is absent. So starting with sensitivity and specificity. Sensitivity is the ratio of true positive to the number of disease. So that is given by A divided by A plus C. So that is 60 by 117. So 51%. Similarly, specificity is the true negative, that is D, divided by total disease-free population, that is B plus D, that is 400 by 401, which gives a value of 99.8%. So moving on to the next topic, that is positive and negative predictive value. We had seen that sensitivity and specificity were seen in a column view, that is in the disease part, whereas predictive values show the test parameters, so that is in the row part. So we can see positive predictive value is given by true positive divided by total positive, so that is 60 by 61, so 98%, and negative predictive value is given by true negative divided by total negative, so that is 400 divided by 457, which gives 88%. So moving on to another topic, so that is accuracy and precision. Though these two might sound similar, but they have a few basic differences. That is, accuracy is how close the measured value is to the actual value. However, precision gives us how close a measured values are to each other. So in other terms, it gives us how closely they are linked to each other. So in this we can see in the top left corner there is clustering of the test results. However, it is far away from the actual value, so it has high precision and low accuracy, whereas in the picture towards the right it is clustered towards the actual value, so it has high precision as well as high accuracy. Similarly, in the downwards we can see that the values are quite distributed and it is away from the actual value, so the accuracy is low. Similarly, the precision is also low. However, in the last picture we can also see that there is clustering of the test results towards the actual value, so it has high accuracy, so it is towards the actual value. However, it is not clustered together as seen in the upper picture, so it has low precision. Moving on towards the Kappa value. So the statistical tool that we use to measure precision is known as Kappa value, and for measuring Kappa value I'll be using this 2x2 table. So for measuring Kappa value we have to do 4 steps. Firstly, we have to measure observed agreement, then we measure the expected agreement for true positive and true negative, then we calculate the total expected agreement, and finally we calculate Kappa value, which is also known as agreement beyond chance. So starting with the observed agreement, here we can see in this 2x2 table both the clinicians are agreeing on 2 parts, so that is on A and D. So positive in both in A, that is 23, and negative in both in D, that is 66. So the observed agreement would be total of these two divided by the total population, so that is 23 plus 66 divided by 100, that is 89%. Similarly, talking about the expected agreement for A, so that is the cross product value, which is given by 28 times 29, so that is A plus B times A plus C divided by the total population, so that comes out to be 8. Similarly, the expected agreement for the true negative column would be 72 times 71 divided by 100, so that is C plus D times B plus D divided by the total population, so that comes out to be 51. So after we have done these two steps, we'll move on to the third step. So measuring the total expected agreement. So that is the expected value for A plus expected value for D divided by the total population. Now that comes out to be 59%. Similarly, after having all of these, we apply these values to a formula for kappa value, which is given by observed minus expected divided by 100 minus expected. And using these value in this formula, we can see that the kappa value is 0.73. So what might be the actual significance of kappa value? So this here shows the significance of kappa value. For example, if the value of kappa comes out to be less than 0.2, so there is poor agreement. That means there is higher inter-observer variability, which means that the test is not accurate. Sorry, which is it's not precise. Similarly, if the kappa value comes out to be more than 1, so it comes out to be towards 1 or more than 0.81, so it is excellent, which shows that it has high precision. So this is the significance of calculating and the inference of kappa value. So moving towards the last topic, that is pretest probabilities, odds, and likelihood ratio. So pretest odds is the chance that the person has disease before performing a test for finding out whether the person has disease or not. So here it is given by the formula total disease by total disease free. Similarly, in the pretest probability, so odds could be converted into probability by the formula odds by 1 plus odds. For likelihood ratio, it is defined as the chance or probability that the person has or does not have a given disease. So that is given by likelihood ratio positive as the formula sensitivity by 1 minus specificity, and the likelihood ratio negative given by 1 minus sensitivity by specificity. So applying these things in this given 2 by 2 table, we can see the sensitivity is 93 and specificity is 67%, and the pretest odds is calculation of total disease by disease free, that comes out to be 0.3215, and pretest probability is calculated from the odds, comes out to be 0.24, and the likelihood ratio here for the positive one using the sensitivity and specificity values comes out to be 2.8, and the likelihood ratio negative comes out to be 0.1, and these are calculated using the formula which have been said earlier. So talking about the post-test probability, so it is the probability of having a disease after the test is being performed. So we could do this by using a nomogram. Here these were the pretest probability value of 24%, likelihood ratio positive and negative. So if in this line we calculate from the pretest probability, drawing a line towards the 24% and keeping the likelihood ratio of about 2.8, and we draw a straight line, then we can see it comes towards 60%. So the post-test probability positive would be 60%, and similarly doing that for the likelihood ratio negative, we can see that the post-test probability comes out to be around 2.5%. So this is the significance of nomogram. However, since it is not always practical to use nomogram in daily situation, so we use formula. So the formula is post-test odds is equals to pre-test odds times the likelihood ratio, that is positive or negative depending upon whether the post-test odds are to be calculated positive or negative. Similarly, probability could also be converted, found out by using odds. So since sensitivity applies to a patient with disease and specificity applies to a patient without disease, how do we know whether the person has disease or not before doing the test itself? So there comes the role of likelihood ratio, which combines the both sensitivity and specificity. However, the problem is that there are two likelihood ratio. One is positive and one is negative. So how do we know which one to give emphasis upon? So the answer to this is a term known as diagnostic odds ratio, given by the formula likelihood ratio positive by negative. And the gist is that higher the diagnostic odds ratio, more suitable design in clinical use. So this is the take-home message for today. Here we can see the 2 by 2 table and all of the formulas and definition that we have talked about in this presentation, and these are my references. Thank you.